with my image or okay, that's one. Let me adjust one thing. Yours that shouldn't open there. Okay. Okay, so 3 images. Vomiting Labrador. And it's not a spectacular case, but I like bringing cases from the clinic because they kind of represent everyday situations. So I think it's worth going through them. Okay, so take a look. Again, you can either go through the chat, click the link, open the images in your computer, and or look at the images through my monitor. Alex, I'm not sure you know about this one. Okay, I'm sure Helen knows because I think it was her case, and I talked to her about this one.
No, I don't know this one. I don't get all the.
Yeah, you don't know one, but Helen knows because actually she confirmed the diagnosis. I remember her coming. So is it going to be a boring time for Helen? But yes, if you don't know, then there's an interesting one.
Yeah.
Again, it's not a spectacular one. It's kind of an everyday situation. It kind of makes sense that you are quiet because this, there are different. We always talk about this, different degrees of difficulty, and sometimes the difficulty. We've seen many cases where the difficulty is not so much to identify the abnormality, but it's obviously abnormal, and then the hard thing is trying to
work it out,
unpack that and figure out and go forward with that information. This is like that. This is kind of the opposite situation where the tough thing is identifying a small thing. Once you see it, then everything, you kind of explain everything, but it's not so much your ability to explain something, is your ability to identify something. So
I guess the first thing that pops out is that there's good serosal detail. You can see the liver and the spleen outline and the bladder outline quite easily on both, well, mostly on the right lateral, but also on the left lateral. And I think the angle of the stomach on the right looks looks fine. So I'm not too worried about a massive liver or a teeny tiny liver. Yeah, and I guess I haven't really comprehended what it means, but it looks like on the left lateral that there are kind of 2 populations of slight, like very minimal gas dilation in the intestines, but I'm just tracking them now to see whether I think maybe one of them might potentially be colon and then the other small bowel, but I haven't pinpointed it yet.
Cool. So remember again that this story about the 2 populations, the way that these 2 populations, or how we define these 2 populations, is in terms of diameter and not in terms of content. Okay, so within the normal diameter, it could be gas filled or fluid filled, and within the distended, it could be gas filled or fluid filled. Okay. So it's an interesting case because in this one, it's kind of, there are clearly 2 groups. One where there is mostly either empty or a bit of fluid, and then the other group where it's gas filled. We don't really care about that separation. The feature that divides these 2 populations is the diameter and not the content. Then if then the content is the distribution of the content is similar to this feature, meaning if all the distended bowel loops are going to be gas filled, and then non-distended going to be fluid filled or empty, then that's a different chapter. But we really, the distincting feature is going to be the diameter and not the content. What I would add is that, not always, but I think after looking at many cases, you may come to the impression that the distended bowel loops are usually gas-filled. I think that's not true. The reason is because we identify gas-filled bowel a lot easier. So then sometimes in a very clear case, and we can go through cases where we've been dealing with this mechanical obstruction, sometimes there is both distended fluid field and distended gas field, and almost 99% of the time, everyone points to the gas field distended. And it's not that there is no fluid field distended, it's that it's harder to see.
Yeah, okay.
But again, this is all to stress the idea of what we are after is the distension, and then the red flag, the thing that we always need to be concerned is what you mentioned, which is making sure that what we identify as distended is actually small bowel and it's not colon. Okay, so this is the simple reasoning, and I think it's a proper reasoning in a vomiting dog and more in a Labrador. Makes sense because we are trying to rule in or out the obstruction option.
And I guess
So,
on that point, if you look at the right lateral near the stomach, I don't know what it is, but something is very circular, and I don't know if that's just gas happening to sit like that, but it looks weird.
can you show us that, or can you point to that?
Yes, I believe so.
But before we go there, what's your conclusion? Because you brought these two populations and then I started talking. So what's your conclusion about that point?
Well, I guess they're not massively distended and there's not a huge, most of them, but I do think that this population here is more likely colon because of how it tracks. Wait, I'll draw it. That kind of tracks like that. And so I think that might be this population there, but I'm not entirely sure.
Cool. So
More
I
like
would agree with that. I think is this, remember, it's kind of a question mark, always kind of the same in the DV or VD, sorry. So that's perfect. I think we are right in saying that this is very likely that. So then if we are based on position, if we believe that this is ascending, transverse, and descending colon, then I think we are right. Sometimes that going from one image to the other and feeling certain that we are pointing to the same structure is not that easy. But I think in this case it is. So I think that's colon and then descending. Remember that if you put this on a lateral projection, there's going to be some superimposition of ascending, transverse, and descending in the cranial abdomen. Makes sense? So if there are too many bowel loops here, it doesn't make sense because it's not just one, it's ascending, transverse, and descending. And then as you go here, there is only one. And then another thing that I want to ask you, just I'm going very slowly through kind of small features, but what do you think is this?
Cecum?
Yeah, so that's cecum. So this is a classic thing. So the cecum, it goes in the right cranial abdomen. Usually, if you go to the book, it says at the level of the second lumbar segment. In this case, it's a bit more caudal, but I guess it's biology, it's not that, we have a ruler there, but it's perfectly fine. So it's a bit more caudal compared to the ascending and transverse and descending, that part of the descending colon. So this is a very nice image. And then I suppose that, for example, these two make sense. So cecum kind of looks, they are kind of at the level of the kidney. So this is the caudal border of the right kidney. This is the left kidney. So it's usually in this area, and then that's the colon. So again, this is going in details for a normal structure, but the more confident we are in identifying this structure, the easier it's going to be our diagnosis of an obstruction. That's why I spent so much time.
Yeah.
Okay. And that show me the other thing that that someone else pointed at that, but I think that we may be having some technical issues again.
This thing. Can you see?
Okay. So tell me more about that.
It's too perfect. It seems
Okay.
it's a gas-filled structure. I'm not sure if it's like, it just seems too round to be a perfect end-on intestine or part of the pylorus or something like that. Like, it's very perfect.
So it's perfectly rounded. Okay.
Mm-hmm.
So what about the opacity of that object or of that thingy?
It looks like it's potentially gas-filled. Like, it's more radiolucent than surrounding tissue.
Mm.
Yeah.
And if you zoom in on it, it's got these kind of like little fine lines, which you don't really see in any normal structure in there.
Is that a fluffy?
So yeah, I agree. And that was my comment was directed to that, because I think so I see that, and I remember looking at the images, I was tempted also, but now that I look at them again, so there seems to be two components to this. So one is that perfect thing, and the pylorus is kind of a perfect structure. But the other one, but that is somehow, if you draw a line around that, that is showing you something inside of that line that it should be radiolucent or less opaque compared to fluid. So gas filled or something radiolucent. Now, within that, and not, I wouldn't, I would be careful using the word within, but superimposed probably. So it is this structure. And I like how Helen described that. It's too perfect. The lines are too perfect. We don't expect anything. So if we can manage to locate that object within the dog, makes sense, because we need to make sure that it's not superimposed. We have only one lateral projection. So we need to make sure that there is nothing on the skin that someone put and has that pattern that is too perfect. Nothing within a dog, nothing within a normal dog has that opacity and that perfect or like straight angles and parallel images. So I think, and then the next step is, can we identify this? Can we, now that we kind of think that there is an abnormal object, can we locate it? Again, because in theory, if you just take this radiograph, that object could be anywhere from the right skin, right wall, right abdomen, left wall, left skin. Makes sense? So all along that, so if you come here, it can be anywhere along this line. So can we see it in any other projection? I'm going through what I think should be kind of a thinking process. Makes sense? And we make it almost painfully slow because we want to make sure that, I think that that's a way to learn. The way not to learn is just to have a photographic, say, well, that looks like this, and that's it. You close it and you move on.
Mm.
We are painfully going through all the thinking process that should be behind any decision. Makes sense? So yeah. So then we identify that, we say based on it's almost always the same, based on size, based on shape, based on opacity. We feel happy that that doesn't belong to the dog. And in a vomiting dog, I guess the idea is, how certain are we that it's a foreign body and where is it? So first, is it within the dog? Second, if it's within the dog, where is it? And third, does it fit with an obstruction? Yes, no. So all of those are the questions that we need to be answering now.
Mm.
I don't know whether, Alex, do you want to go on or shall I?
No, go for it. Absolutely.
Well, I mean, I think you can see it in the three views. So if I get my pen, annotate. Or, so, I mean, you've got it there. I think you've also got it. When I'm looking at your pictures, Mariano, I can't expand them, so I can't see this as clearly, but it's there. Yeah, okay. So I'm going to delete that now. Erase.
Sorry, I'm moving your target.
You tricked me. Clear. Let's try again. I think it's there. I can't see. Yeah, because I think you can see the striations on it there. So I think it is sitting in the pylorus.
Okay.
And I guess the thing that interested me is, and I'm not sure about this, is because you can see those bits of intestine here that, as Alex said, are all, well, I don't think they're dilated, but I'm wondering whether they're bunched up because they're all on the, let me get this right, on the right side of the abdomen. So whether there is some kind of linear effect, I don't know, or is that just my imagination? Might be.
Why are you saying that they're on the right?
Because that's the left side of the abdomen with the fundus there, or is that X-ray back to front? Okay, let's just clear that. Hang on. So I think the intestines are all down here.
Huh.
And there's very little on the other side.
Okay, yeah, there is still like, if you, this is bowel there, and I don't know about that. Yeah.
Oh, well, you didn't like that, did you?
Okay, but now you're yeah. So you kind of identify things that I guess if you bring them together, the way to call them is kind of a clumping or bunching of the bowel, and then. Am I right that you want them to be kind of stacking?
Well, I'm worried about a linear foreign body. I don't see them clearly stacking, but particularly on the left lateral, you've got the, I guess you've got these lines that just sitting all, I mean, it could be just a natural position. I don't know, but I mean, that could just be a ball, some kind of ball in the pylorus, in which case it's nothing to do with a linear foreign body. But I'm wondering with all those striations on it, whether it is something different and there might be some changes or some linear component to it.
Well, so that thinking process and that idea of, well, there's something in the pylorus, I suppose you haven't said it, but what is the underlying thing is that, well, things stuck in the pylorus may not be only that component. They may be anchored in the pylorus, and then they may extend in the bowel, and therefore I need to check if there is any evidence of a linear foreign body. So I like the idea and the trigger, let's say, to say, well, let's see if we see something like that. The point that I don't agree that much is that we do have evidence of a linear foreign body. So let's recap on that. So the bunching is okay. So we get bunching when there is a linear foreign body. That's one of the features. But remember that that's not, let's say, very specific, because if you have mass effect, if it's a bit rotated, so the bowel is telling, so it can be grouped together. Like another example would be a very fat cat. All the fat in the abdomen is pushing the bowel to the right in the abdomen for some reason. So remember that is not a strong enough feature on its own. So in this case, I think the distribution of the bowel is kind of okay. But even if you disagree with me, remember that feature on its own is a relatively poor feature, because you can find that feature in many other situations. Probably another feature that is a lot more, is a lot stronger to think about a linear foreign body is the plication, and then another way to call plication, it would be a kind of triangular eccentric gas opacity. So where can I find? Oh, I know. Let's use our nice book. Okay. Oh no, I wanted to use this one that has a lot of graphic. And well, probably I don't like this one that much, that graphic. See also figure. No, I don't like it that much. So probably I can try to draw. So what I would expect is the bowel looking something like this. So that on one side, and then something similar on the other side. Makes sense. So it's kind of so the way to think about it is, and I think we got a case, is the linear form body is traveling through the bowel. So if it's not attached or if it's food, then content can move aborally, okay, move caudally. If it's attached, that motion, so the small bowel is extremely efficient in the peristalsis in moving things aborally or caudally. Make sense? So if that thing cannot go caudally because it's attached, then what is going to happen is the bowel is going to climb, and as it climbs, then there's going to be a point where it cannot go anymore cranially, and then so the bowel, instead of being normally like this, like elongated, now it's going to be all kind of clamped together. And then if you do that, then the border of the bowel is going to be like this. It's going to have like not an undulating, but yeah, what we call plication. And then if you add to that idea, then the gas in that bowel is not going to be in the center, but it's going to be in the periphery. And the gas is not going to be linear. The gas is going to be in little triangular pockets that they are peripheral. So that's the image that, yeah, I think we had a case before. I'm happy to probably review it for next time. But probably if I come here, this is very long.
Straight. Yeah.
So this is actually telling me that there is no linear form body. If I see this, so see that there is no curvature, it's just nice elongated, then that actually makes me think the opposite. I see what you mean. I think there is still, in terms of the distribution, it's not clamping, if you want, or bunching in the lateral projection. There is bowel caudal, bowel more cranial. So it's a very nicely distributed bowel in the lateral projection. So yeah, good opportunity to go back and think about that. And then, so I think I kind of celebrate all these triggers, because this is the actual real life situation where we need to go and recall that knowledge and then have that mental representation and see if that fits or not. Yeah, I hope I trigger enough things maybe for you to go back and look at those. I'm the feature of linear form bodies. I'm gonna go back now in a minute because I'm pretty sure we've been through some cool cases that would be good to review the images for you.
I'll have a look
try to
too.
go
That's
through
good.
it in a minute.
That's good.
I'll show you.
Yeah.
Then the next point that you mentioned that I think is an interesting one is that you said, I think the linear form, the foreign body is in the pylorus. So this is a nice time to talk about, or my next question will be, do you think it's stuck in the pylorus or do you think it's moving? Because I think radiographically we can make that call. Probably it's not gonna be all or nothing call, makes sense? Because this is based on what we see, based on the minute that we've taken the radiograph. Do we see evidence that the foreign body is moving in the stomach freely, or do we think the foreign body is stuck in the pylorus? And that is also an interesting question to answer, even if you keep on thinking about the linear foreign body. If you think about a foreign body and a linear foreign body, in that situation, you want what you see of the pyloric foreign body to be stuck in one place. Makes sense? So this also is a little bit of information that it works either way, and it's a very good piece of information that hopefully we can get. And we usually can get, and I think we can get in this case. So what do you think? So this is a right lateral projection. This is going to be a left lateral projection, I suppose. Let me see. Yes, it's a left lateral. So do we think is kind of stuck in the pylorus, or do we think it's moving? So now what we need to do is, again, the same thing, is bring our expectations, know how a foreign body that is stuck should look like, know how a foreign body that is not stuck should look like, and contrast that with what we see. So we can go either way. We can first recall how it should be, or we can first define how it looks and then make a conclusion.
If it's stuck there, usually the stomach's really big and the stomach is empty, but the dog had just vomited, so that can confuse things.
Good. Another confusing point. So that's very good. So if it's stuck, then we assume this is not necessarily like this, because there could be a foreign body that is stuck, but is not producing a complete obstruction. And I'll give you an example of something sharp or something that allows content to go through. But I take your point, and I think he's right most of the time. So if it's stuck, it's going to be obstructed. That same point, if you put it in the small bowel, I think the evidence of obstruction or the evidence of accumulation of fluid is going to be a lot more persistent. In other words, it's not going to be so dependent on the animal vomiting or not. In this particular case, then we need to always have that in mind, that we expect the consequence of the obstruction, which is the distension, whatever is more oral, but it may not be there because the animal vomited. So very good consideration of the reasoning and also the exception to that reasoning. Any other argument other than the stomach being distended to conclude that the foreign body is stuck?
This might be incredibly wrong, and it's purely just a theory, but on the right side down, you should see gas around the pylorus. And if we think that the ball striated foreign body thing is in the pylorus, then I'd expect to see gas rather than it would fall into the stomach, or it would be surrounded by gas, which might make it harder to pinpoint. So it makes me think that it is surrounded by something that's soft tissue density. So it could be like the wall of the pylorus, because fluid should fall to the other side. Does that make sense?
So let me not rephrase it, but see if we are on the same page. So what you are doing is you basically you contrasted what you see with what you are meant to see, or how it should work. So let's do first in the right lateral projection. So we know that the pylorus is on the right side. So if the animal is laying on the right side, and then we assume that there is fluid and gas in the stomach, then fluid should be in the pylorus, and we shouldn't see anything gas-like or radiolucent in the pylorus. So if that is our expectation, and then we have a right lateral, then we want to see gas. So, and then if we see these, then that, I think you are allowed to conclude, or to think at least, that these, whatever is inside, whatever that radiolucent thing is not gas. Makes sense? Because if it were gas, it should have gone to the other side. Okay? So then I think this helps to at least start thinking. And then we have So there are two arguments now here. So is this a radiolucent foreign body surrounded by fluid? Because we are in a right lateral projection, and if that were a gas, should be in the fundus. And the second is if these mineral opacities or mineral linear thingies that we believe is a foreign body also is in the region of the pylorus, because based on gravity, if it's not stuff, it should have moved to the left. Oh, that's wrong. What I'm saying is wrong, because gravity should have moved this to the right. Okay, so what you said is correct. So fluid should be here. If we don't have all fluid, then maybe something that is not gas, makes sense, which is the foreign body. My second argument is not correct. My second argument, forget about it, because gravity should have pushed this to the pylorus, which is on the right. But that argument works if we come here. So if we come here, and this is a left lateral projection, the animal is laying on the left. So we expect gas to be on the right, and we expect the foreign body to have moved to the dependent side. And so if the foreign body is not stuck in the pylorus, then at least in this radiograph, and again, this is a thing. This may not be stuck there forever. You may do endoscopy and you may find that it's not stuck. But radiographically, these are the arguments that we use. So if you have a left lateral projection, things should fall to the left. And then here, this, which we believe is the foreign body, that is in the pylorus, is in the region of the pylorus. It's not, so something free in the stomach should be sitting here, which is the fundus. So this image, both arguments I think are good. One is this perfect thing that is telling you, well, we don't expect any gas in the pylorus, so a lucency there in a right lateral projection should make us think that there is something kind of further supports the idea of a foreign body, in addition to that linear pattern. And then if we come here even more, because if that would be free in the stomach, then this should have fall in here, and it hasn't. So then it's likely that it's not only a foreign body, it's not only in the stomach, because we could localize it here and not outside the dog, but also that in the three projections, another way to say this is regardless of the position of the animal, you move the animal 3 times, and it seems to be always in the same position. Anatomically, it makes sense. It's always in the pylorus. That is, again, we are painfully going through the whole detail of how to make that call.
That makes sense. I like that. I like going through the detail.
Okay, and this was a cork.
Oh, really?
Yeah.
So the striation was like the pattern of the.
Yeah. So we haven't, but we should next time take a radiograph of a cork. I've never done that, and then now in my eyes, if I tell you, this is a cork, I think I can explain that, that linear pattern and that square appearance there, and then I think here. The only thing that didn't fit is that I remember Helen telling me, it was floating in the fluid. So I suppose this stomach is quite empty. So maybe the dog vomited, and then the less amount of content kind of kept that foreign body in between the walls of the pylorus. And then maybe there was a more swallowing, a more accumulation of fluid, and the distension of the stomach. That is a small foreign body. So it may have made to go swimming. I would still, even if it looks small, I think it's a concerning foreign body because it's not small enough to go through the small bowel. I think this going through the small bowel, it would have resulted in a lot of vomiting and probably having to go and remove it from the small bowel.
Did you scope it out, Helen?
Yeah, we scoped it out, and the dog had already had, it was only one, and this would have been its 3rd X-lap. If it had to go to surgery again, it's already had 2 X-laps, so she was very grateful that we picked it up. But the dog had gastroenteritis, that's why it was actually that's what was all that stuff in the colon. So it developed spectacular diarrhea. So I think the cork was a bit of a red herring, but she was still very glad that it was out.
Yeah.
Yeah.
Did you scope it yourself, Helen?
I tried to get it for ages, and it was so annoying to get the snare around it. So in the end, Liz got it for me, but I almost got it about 3 times.
Oh, it would have been really hard. So slippery.
It was just buried in saliva, like really thick saliva, and it was so slimy. It was very hard.
Yeah, you'd think it'd be easy, wouldn't you, Helen? But it
Yeah.
isn't.
No, they make it look so easy.
Oh, they do.
Mariano, there's my internet went out at one stage, but there's a soft tissue density there. And I didn't know whether you'd discussed what that was.
No, because let me see what I think it may be. I think we are dealing with a skin fold. Two things come to mind when I see that line. So first, I'm gonna think aloud. Thinking aloud is, well, if it's gonna be an elongated structure, I think I can continue the line. Let me draw. So if I continue, I think the line comes like this. So if I'm gonna have such a large structure, and I'm not sure where it comes on the other side, because on the other side, this is not the border, that's the colon. So I'm not sure I see the other side. So if there's gonna be something that big, and eventually I should be able to see it, if that's gonna be something that big, and it's gonna be in the abdomen, it should be displacing stuff, and the kidney is not displaced, and I think the bowel is here. Okay, that's one point. Second point. Now I'm that I could see, so that I can make that line go out. Makes me think that there is a mixture of at least one of those lines is a skin fold that it makes us think like that. Another possible explanation is that the spleen is coming along the left abdominal wall. It seems that the spleen is a bit, so it goes from the attachment, which is the gastrosplenic ligament here on the left. So this is kind of the more fixed. I think if out of all these lines or structures, I probably would pick that as more likely to be spleen. It's not the perfect, the classic image. I'm more happy with this being the classic image of the spleen. We don't see it in here. So one option is that the spleen is occupying some of that left abdomen. Yes, and that explains one of the lines. The other line, in particular, this one that seems to be coming out of the abdomen, I think is a skin fold. And the third option to explain a line like that is not a skin fold, but the sublumbar musculature that it gets superimposed. So I think there are 3 options to explain that, or 2 options. One is a superimposition, either skin fold or sublumbar musculature, probably both. The sublumbar musculature is very prominent in cats. In cats, you can see that line very, very clearly. In dogs, usually it's not that clear. Then the other one is a skin fold, and the way to deal with them is to follow them, and if they go out, that means that there is nothing inside of the abdomen. And the third option is to look for an anatomical structure. In this case, because it's the left, I think part of the reason why the small bowel is more to the right and there's kind of an empty thing is because maybe the spleen is occupying that space. Now, if I'm gonna think aloud, entertaining the idea of is that a mass? Could that be a mass? So I don't see the clear borders. I don't see effacement, and I don't see a lot of displacement, which will be the thing. So if that is going to be a mass that big, I would probably expect to see it in the lateral projection. I don't see that. And we still see the borders of the kidney and the structures that are in there. So that is telling me that whatever is in there is not against those things. It's not silhouetting with that structure. So yeah, so I see what you mean. I think there's a mixture of skin folds, maybe spleen in there that explains that.
It wasn't symmetrical, which had me intrigued.
Yeah, absolutely. The asymmetry is worth
But
trying
now
to
that I look at
explain.
it more carefully, it's made up of a number of different things. You can see borders of objects around it, within it, such as the one that I drew a minute ago.
Those these kind of discussions about what is this, how can you explain that? This, I mean, if you like to engage in those discussions, in my eyes, is because you like imaging, so and radiography in particular. Because at the end of the day, I don't know if you realize, half of the conversations that we are having are due to the limitation of the modality. So the whole discussion about where is that object? Is it outside? Is it inside? Is it stuck or is it not stuck? Those are things that are, all those discussions are due to the reducing a 3D object into a 2D image, and then how to deal with that, having different projections and reconstructing the anatomy and the behavior of something that changes during changing the positioning. That probably is not a problem in ultrasound. The problem is going to be trying to find it, trying to get access. But then there's going to be less of a problem. And probably the ultimate example where that is not a problem is in CT. Makes sense? So you see something inside the stomach or outside the stomach. There's no problem with it's in this projection or the other projection. Can it be in the skin or can it be in the stomach? That problem is gone. We have other problems, but that particular problem is gone. Your problem about is what is happening here. That's probably a situation where it's not going to create any question in CT because there is no superimposition. Part of my answer was, is that a superimposition of a skin fold? Is that a superimposition of the border of the musculature? That problem in CT is gone. Again, no superimposition of stuff. So if you like that, means if you like engaging and you don't think that it's a waste of time, then you like radiology. I love it. I love to interact with people that bring those questions, because then it triggers, how can we answer that question? And it's all the thinking about the 3 dimensions, the 2 dimensions, and the different positioning, and then the different anatomy, how it looks, not in the book, but how is anatomy looking in a radiograph, and how can you bring that, to explain something like in this case, what do you think is happening in that part of the abdomen? Okay, so as usual, we spend a lot of time with one case, which I think is perfectly fine. It's a way to really dissect all the thinking and then making sure that we are going through the right path, or we identify where we go wrong, but not just seeing something and assuming an answer right away. This may happen, but I think the learning may happen in the future when you are more experienced. The learning is the making sure that path from seeing something to concluding something makes sense. That thinking process makes sense. So we spend the hour doing that, and that's okay. Next case is in the family. So it's a similar topic, but a very important radiographic concept. So take a look, and we discuss in 2 weeks. It's the same flavor, but different.
Sounds good. Thank you very much. That was a cool case.
Cool. So we'll see each other in 2 weeks.
Okay, thanks, Mariano. Thanks, everyone.
Thank you.
Bye.
Have a good
Good.
day.
You
Bye.
too. Bye-bye. What's it?